Welcome back, guys, and today we're going to be covering the topic of psychiatric emergencies. So this is a self-contained unit of the class. It's worth 1 credit hour. It's a one-and-done test. It's a 50-question test. But we got a lot of material to cover in that 50 questions. Make sure that you, number one, read the book because, again, it's a one-and-done, okay? So make sure that you do that, all right? So let's talk about the psychiatric and behavioral disorders. Unfortunately, it's a kind of a lot of things that are misunderstood about this topic. And I will tell you that we get called to this a lot. And the reason that we get called to this a lot is because simple fact of the matter is the police either don't want to deal with it or they don't know how to deal with a certain situation. And because of that, and so many times we miss medical conditions, even though they're having a behavioral emergency, there's some sort of medical underlying issue that's causing it. And there can be medical causes for behavioral and psychiatric emergencies, and we need to make sure that we understand that concept. Okay. We observe behavior gathering. And if it's the one thing I can tell you about a behavioral or psychiatric emergency, we're geared towards fast. This is actually the time we really got to hit the brakes and go slow. And I know that that's kind of difficult, and sometimes we get some people that really get upset about that. But again, this isn't the patient. This is the patient that you might spend 30, 40, 50 minutes with before you even get them convinced that they need some help and get them to the hospital. Okay. And by the way, the hospital might not be the place that they truly need to be. Okay. So again, a behavior is a person's observed conduct and activity, and a behavioral emergency is behavior that's so unusual, bizarre, threatening, or dangerous that alarms patients or other persons. Okay. They're a danger to themselves or others. Okay. Requires intervention by emergency service or mental health professionals. The third part of that might be requires law enforcement intervention. Okay. Because yes, if they are violent, yeah, we're going to need somebody there to make sure that the violence doesn't super escalate where they're going to hurt themselves or others. All right. So what is the normal varies between on culture, ethnic group, socioeconomic class, personal interpretation, and opinion? That's what makes these things so challenging, okay? And by the way, what is normal behavior, okay? Considered readily acceptable in a society. And boy, you can go off on major tangents on that. Is it acceptable to wear a mask during a pandemic? Boy, you could see where that would get complicated in a hurry. Okay, so again, objective factors, it's able to function in core life. They're able to eat, sleep, interpersonal relations, sexual relations without any problems. They pose a threat to life or well-being of the patients or others, significantly deviate from society's expectations or norms. You know what? I'm going to go out today and just kill 3 people. That would be called, I have the feeling that I want to go kill 3 people. That's not an societal expectation or norm, okay? And it's very important that you understand that. 20% of the population has some type of mental health problem. By the way, the number one thing showing up in emergency medical service, fire service, police department personnel is mental health problems. Stop and think about it. By the way, we are 3 times more likely to require to have mental health problems than the lay people. Stop and think about that. 60% of the first responder patient has some type of mental health problem. Let that one sink in for a smidge. All right. 1 in 7 may require treatment for emotional disturbances. Multiply that by 3. That's how many that may require it from EMS workers. Stop and think about that. Now, again, the type of psychiatric conditions exhibited bizarre and unusual behavior is actually sometimes there's a misconception with that. And the behavioral psychiatric disorders, they can actually incapacitate people than no other health problems combined. If you're on an ambulance and you get constantly mandated 48 hours, 48 hours, 48 hours, 48 hours. You're constantly doing that, and you do, let's say you get mandated 8 times over the span of 1 month. Stop and think about the depression, anxiety, absolute exhaustion, fatigue. Not talking the physical parts of it, the mental parts. Seeing all of those things and not being at your best. Okay? Many patients are cared for in the outpatient setting, up to and including a lot of emergency service workers, as they should be. And only those with severe psychiatric illnesses usually remain institutionalized. Okay? A very small percentage are institutionalized. They have such behavioral psychiatric problems that they actually cannot function as in a normal society. Okay? The common reasons for EMS interventions is the failure to take their psych meds. Okay? So when I'm dealing with a psych patient, the first thing I do is I ask them, and there's a nice way to ask it, are you on any medicines for your problems? Okay? Did you take your medicines like you were supposed to? And again, can I see what medicines you were on? All right? Because we've talked about that. Tricyclic antidepressants, selective serotonin reuptake inhibitors. All of these things have some really nasty side effects, and if taken incorrectly, actually make the problem worse. Okay? So suffering from mental disorders is not a reason for embarrassment or shame. And I think that's one of the biggest obstacles in first response ever. Just because you are going to see a mental health professional means that you're broken or you're mentally unstable. Matter of fact, I think as an EMS worker, if you don't go see one of these people, that your problem, I think, is actually bigger. Okay. Society often stigmatizes these patients unfairly. And again, anxiety is real, especially in an emergency responder. The things that we see and do, gang, changes you. Okay. It does. And I think that you really need to take a look at that, and don't be afraid of seeking mental health counseling. I think you're crazy not to. Okay. So there can be biologic problems. There can be psychosocial or sociocultural issues that cause the need for a behavioral emergency. Okay. So again, just remember, and this is why we get called a lot, because we want to really rule out this guy right here. Is there a medical reason or a natural reason that this person's acting the way that they are? And yes, there are plenty of them that do it. Infections, tumors. Again, it's not just purely psychological. Abnormalities, electrolyte abnormalities, high levels, medical conditions changing. So changes in the blood chemistry can change brain chemistry. Okay? So again, you got to make sure that take a look at their psychosocial interactions. What is their lifestyle? What do they do? Do they have unresolved conflicts? There's oftentimes we're called to a chest pain patient. We get to the chest pain patient, and the poor little lady, she's faking chest pain because she wants to get away from an unresolved conflict there at the house. Okay. Very common thing to happen. Okay. These disorders are also contribute to substance abuse or medical conditions. It is actually rather scary to know how many people in the emergency medical services field actually drink a lot more alcohol than they should. And probably the worst case thing is the binge drinking. Okay. And again, by the way, when the binge is over, the problem's still going to be there. Newsflash. Environment plays a part in large social development. So again, there are people that are privileged that are able to get help and resources, and there's other people that are not. And a lot of times we get called to those because they don't know what to do. Let's not forget that people do really bad things to children, or things happen to children, or they have dysfunctional families, abusive parents. Drug and alcohol abuse, neglect is just as bad. Okay. So all of these things can manifest. And again, they can, even if they learned it as a child, they're probably going to do it as an adult. I know it's a huge stereotype, and there's probably certain people that are watching this right now going, ugh. But look, I'm speaking as an overall trend and not specifically. By the way, the flip of that's also true. I think that you're able to break that cycle. It's a matter of the ability, the resources, and the will in which to do it. Again, when you're dealing with psychiatric or psychosocial disorders or sociocultural disorders, again, you're dealing with a region that, even though it's been studied greatly, it's far from an exact science, and what might work for one person doesn't work for another. Okay, and it's very important to understand that. Events that can cause profound psychological changes, by the way: rape, assault, victims, deaths, acts of violence such as war or riots, pandemic. Okay, that one, you think we're not dealing with that psychosocial issue? I can assure you that we are. Okay, and again, events that leads to the over time loss of job. They can have economic problems, ongoing prejudice or discriminations, and it's very sad to say, but yes, your history does kind of shape how you believe and what you believe in. So assessing these people, how do we assess them? Okay, again, first things first: scene safety, scene size up. Again, none of that really changes, but again, your interpersonal skills. Remember, slow down for this call. Don't rush in there and think you're going to solve the emergency problem in 10 minutes in this case. Definitely you're not going to do it. And by the way, if there's any doubt about scene safety, any doubt, call for law enforcement. Okay? And again, most patients that experience them, again, most of them will not attack you. There are a small fraction that will. So be ready for that, okay? Number one, be ready to get out of there, escape, and we're going to go over that when we go through defensive tactics, okay? And again, this guy right here, yeah, he's got a baseball bat. We're good. We're just going to, you know what? Hey, dude, you got some issues. We understand. You know what? We're going to go back to our truck, and we're going to send somebody here to help you, okay? And again, you should have police assistance for this, okay? Any chance that you're going to get hurt, absolutely. Look for your evidence of substance abuse. Is there pills everywhere? Is there syringes out and they're not a diabetic? Okay. Do they have track marks on their arms that you can visibly see from across? Okay. Signs of things being broken and they shouldn't be. Observe for patterns of patient from the distance. Okay. If I'm going into a known psychological behavioral issue, I'm going to feel that person out for a little bit. And we got some things we do in DTAC that's going to kind of say, hey, this is how we're going to do it. All right. So primary assessment, make sure your ABCs are there. Again, you want to take a posture that, and you want to take kind of a relaxed, you don't want to be in an aggressive stance. Okay. You don't want to be in an aggressive posture because again, when people are confused, or they're altered, they're going to assume the worst. Emotions such as rage, fear, anxiety, the dark side are they, okay? Very much true. And unfortunately, when you're on the dark side, you're not exactly thinking straight, okay? So determine their mental status, the cerebral functioning. Again, control the scene as soon as possible. Again, you want to control this scene. You don't want to let that scene control you, all right? If you got somebody that's agitating somebody or adding confusion to the scene, that's a great time to find them something to do. Boil water. Okay. You go find them something to do. Remove them from the situation. And by the way, if you've got a controlling person, that's going to be kind of a little bit difficult. You might actually have to tie up a resource, maybe 2, maybe 3, in order to maintain control of that situation, okay? Limited number of people around the patient's usually the best. And again, you may actually have to clear the room or go to a quiet area. By the way, the back of your truck, it's actually, I think that's a feel out thing, but most of the time, getting them to the back of your truck is probably a good idea because that's an area that you have control over. All right? So again, observe effects in greater detail, especially if somebody's being controlling or manipulating. That's definitely the back of the truck is where you want to be. Okay. Avoid being grabbed or struck by patients and stay alert. And again, also remember that some of these conditions, they can go from being perfectly okay to physically beating your butt in 1.2 seconds. Okay. It happens that fast. Okay. So look around, look for those signs. They clench their fists, they're backing off. If you're seeing something like that, this is not the time to be aggressive with these folks. Okay. remember, focus on the immediate problems when you start doing your assessments. Listen, ask, spend the time. Don't try to hurry them, because actually the more that you talk and the more in which you get their trust, the better that you're going to be able to help them. Okay. You want to close down a psych patient as quick as possible, threaten them. Okay. Rapid, sudden movements, really bad idea. Okay. Slowly, confidently, don't fear silence. It's okay. Let them process. It's okay for them to do that. All right. Make sure that you place yourself at the patient's level. If you're standing over them, they're going to be going, uh-oh. Again, if you're trying to use the physical attributes, again, I can tell you as a bigger guy, I could kind of get away with that, but I had to be really cognizant of that when I would go into those situations. And I would actually, if I had somebody being stupid, is it okay if I sit down? And I would sit down and they'd be like, what? I'm like, look, I'm not here to hurt you. I'm here to help you. Okay. Make sure that we always keep our personal space, 3-foot distance. And we're going to really emphasize that when we get to DTAC. Because we definitely, matter of fact, we're going to show you some stances when you're approaching it. One thing I have a problem with this guy and his stance, actually, what you want in your stance is you actually want some width and depth so that you can, this guy can be easily toppled over. If I've got this leg right here back just a little bit, if the guy charges me for some reason, I'm now ready to engage that person and defend myself. Okay. But again, you want to be comfortable. You don't want to be judgmental. And a lot of times, and we're all guilty of it to a certain extent. This is the time to listen and try to find out where that patient is. Okay. And they need to believe that you're interested in their welfare, and we need to take the time to get there. Okay. Yeah, I've said this, more than one time. Don't lie, don't lie, don't lie. But definitely don't lie to your patient, and don't give them false beliefs or mislead them, because that's gonna definitely, you got to be honest with them. You absolutely have to be honest. You really do need to do a general appearance exam, and again, look for the verbal and nonverbal things, facial expressions, how fast or slow they're talking, their volume. Again, if I got somebody who's really, really quiet and then all of a sudden burst out into anger, I'm going, that's the one ready to explode. I need to back for just a second. Okay. Again, orientation. Do they know where they're at? Do they know others are? Do they know current events? Again, simple questions. What year are we in? What month are we in? Yeah, who's the president? Oh, yeah, that's a good way to blow that out of the water. Don't use that question. Is the patient's memory intact? Again, and is the patient focused? Do they lose focus? Are they paying attention? Do they nod off if I quit engaging them? Okay. Again, what is their thoughts? Are they actually, in matter of fact, if you guys look at SOAP PCR under the psychiatric or the mental status, a lot of these happen to be there. Okay. What is their mood? Are they showing signs of depression, elation, anxiety, agitation? Is there something else that they're doing that's just not normal? Okay. Are they able to process their thoughts? And that's what we're kind of trying to figure out. Okay. And again, do they have appropriate judgment? Are they able to make an informed decision? Wow, that phrase has seemed to come up before. Again, if this person's not able to make an informed decision, should they be making choices about their health care? That answer is no. But we have to assess that, and we have to provide our proof of assessment of that and why we thought that the person was or was not able to make a rational decision. Okay. The patient, again, watch out for the ones, especially that are scratching, they think they got bugs all over them. In their mind, guys, they think that they do have bugs all over them. Okay. Did the patient exhibit any unusual posture, unusual movements? Okay. All of these things come into play. Are they on psych meds? Oh man, look them up, see what they are. The big ones: tricyclic antidepressants, monooxidase inhibitors, serotonin reuptake inhibitors. Okay. MAOIs, SSRIs. If they're on these drugs, you know that there's an issue already. Are they on any calming medicines? Valium, Bospar. Are they on any of those medicines that could affect, their moods or or their mental status. Okay. So again, there's the two diagnostic elements. You got to make sure that there's no disease or disorder, and that they're not getting their impaired judgment from it. Okay. And I've kind of spoken about that in detail about that. So again, guess what? I think we're at yes, we are at the spot where I'm going to break this. Okay. Again, we're going to get into the more specific psychiatric disorders in the next video. The next one is probably going to be super long, guys. So hang tight, and I'll see you on the next one.